Okay. Now you can see the presentation.
Yes.
Yes.
Let's go. So there are two main things that I want to discuss today regarding the chest X-ray, the normal chest X-ray. First of these things is to determine whether chest X-ray is correctly done. So if we can go further and analyze it, because it has all the right parameters to give us the proper information we want. The second thing we have to do is to try to find a way to analyze the chest X-ray. I will give you the way I look and when I start to analyze the chest X-ray, and if it's good for you, you can try it too. Also, we will remind ourselves a bit of the anatomy of the chest. So, four main things that you have to look at when you study a chest X-ray to determine if it's correctly done. It's you have to ask yourself if the film is centered, if the image that you are looking at it's obtained in a posterior anterior position, or inversely anteroposterior, if it's exposed properly, and if it's a good breath hold of the patient. So first of all, is this film centered? What do we have to study in order to determine these things? And it's very easy. I hope you can see. I will use a laser pointer, maybe it's clearer. So in order to establish this thing, if the film is centered and the patient is correctly positioned for the investigation, is to look at the clavicles, which are positioned here in the superior part of the film. This is the right clavicle and this is the left clavicle, and here are the medial heads of the clavicle. They have to be at an equal distance from the spinous processes of the vertebra. So if we draw a line between the spinous processes of the vertebra, which we can see in the center of the image, like this oval shaped opacities, if we draw a line and we compare it to the medial heads of the clavicles, we have to have the same distance, so not greater on the right and shorter on the left, but to be exactly at the middle distance between these two. So what does it mean? And what consequences are there if this is not properly centered? Automatically, there will be a rotation of the heart and the vascular structures of the mediastinum, and we will falsely believe that is something wrong with the patient, only because the shapes that we see on the X-ray will be deformed by the position of the patient. So this is one, and the most important thing that you have to assess when you start analyzing your chest X-rays: the equal distances between the clavicles and the spinous processes of the spine. Just as I said, it is difficult to assess the mediastinum if there is a severely rotated position of the patient. Everything will be disrupted and we cannot make a proper diagnosis. So what do you think in this film? Is this chest X-ray right correctly centered? Someone, please answer.
No.
And why is that?
it doesn't seem to be like perfectly centered, because I think because I can see properly the thorax. Like, I don't know how to explain.
I will continue and maybe we will get it better. From my point of view, and why I chose this X-ray, it was because it was correctly positioned. If you draw this line that I was talking about earlier between the spinous processes that you see here in the vertebra, and you measure the distance between the clavicle heads, you will have the same distance. So it's symmetrical and it's centered. So I don't know if I hope it's clear for you now what I mean about this, because this is a properly positioned chest X-ray. We move on and we discuss about the importance of determining and knowing whether a chest X-ray is done in a posterior-anterior incidence or in an antero-posterior incidence. Just to be a little bit clear, this is how we do the standard chest X-ray. So the patient is positioned with the chest lying on the film. Here is the film. And the radiation source is behind it, so that the radiation beams will go from the posterior of the patient to the anterior, where we can find the radiographic film. This is the standard procedure of the chest X-ray. And it is important because all the things that we analyze on a chest X-ray are standardized for this kind of projection from the posterior to anterior. We get the most accurate dimension of the heart and mediastinum, the proper position of the diaphragms, the most correct characterization of the vessels of the lungs. So when we position the patient on its back because he's severely injured or he's lying on the ICU or on the therapy bed, or he's intubated, or different kind of procedures are being done to him, if he lies on his back in a supine position, then everything will change in his chest. The heart will appear enlarged because of the gravity effect. The same will happen to the vessels that will tend to equalize and be more prominent in the center and in the apexes. We cannot correctly evaluate the pleural effusions in the costodiaphragmatic angles. So it is important for us to determine whether the X-ray was done in a posterior anterior projection or otherwise supine and antero-posterior projection. When we do a classic and standard X-ray in PA projection, we will have the scapulas projected out of the pulmonary lucencies. We will have no shadowing given by them on the lungs. Things that will not happen on the PA projection when the scapula will lie and superimpose on the lungs transparency. Also, here we can appreciate all the mediastinal edges and the heart shape, thing that cannot be done correctly in a posterior anterior film. So each time you see Images like this, where the heart is much enlarged, where the scapulas are projected on the lungs, if you see a lot of tubes and cables connected to the patient, think that he is probably in the intensive care unit, lying on his back, and that the film was done in a antero-posterior projection. Okay, so this is sometimes when we analyze the chest x-rays, even if it is done correctly and it is done in a posterior-anterior view, there are some areas of the lung that we consider them as hidden areas, in which we can easily miss some problems. And these areas are considered here in the hilums, because there are a lot of opacities that are projected one on top of the other, behind the clavicles and behind the diaphragms. In order to have a better view and to eliminate any kind of doubt of some kind of pathology in these areas, we can also do a lateral view. This is what I was talking about. It is the same patient examined on supine position on anterior posterior projection. When the scapula are projected on the lungs, the heart is falsely enlarged just because of the position, and the same patient in posterior anterior view, with a clear view of the lungs, with a normal shaped and dimensioned heart, with clear view of the lung parenchyma, with the vessels with a proper distribution. Here you can observe, if he lies in his back, the vessel tend to enlarge at the upper part of the lung, which is an effect of gravity. Okay, so if we want to determine these fuzzy areas where there are a lot of things projected on top of each other, and we are not sure if they obscure some kind of other problem, we can do a lateral view. This is how it looks. The patient sits with its side connected to the radiologic film, and the radiation comes from the beam from the other side. This is very useful because now we can see very clearly around the hilum, the hidden areas of the hilum, pulmonary hilum. We can see what's behind the heart opacity, because we can perfectly delineate all this happening on the lateral view. We can see partially what's happening behind the diaphragms, because we have another view at the posterior region of the lungs in here. And we can also see some more behind the clavicles in the upper part of the lungs. So this is useful for studying possible hidden lesions in these areas, and it is also useful in case you have a very small quantity of a pleural effusion that you can easily miss on the frontal chest x-ray, and you can see very clearly on the lateral chest x-ray, because this is the more dependent region of the pleura, and the first pleural effusion that accumulates, it sits here in the posterior costo-diaphragmatic angles. The next thing that we have to do is to determine if the exposure of the patient was done correctly. It means that if we do not adjust the quantity of X-ray that we direct to the patient, the overall appearance of the chest X-ray can be altered. normally, to be sure that a lung film is correctly done, we should see only the first 3 or 4 thoracic vertebral bodies in the upper part of the thorax. And this will give us the certainty that we have a correctly exposed film. If we have this kind of image in which the lungs appear to be very, very dark, and we can see basically all thoracic vertebrae, then we call this an overexposed chest X-ray. And what happens next is that if we try to determine whether there is a lesion or not in the lungs, we can probably say anything, because we practically cannot see lung parenchyma. So any small lesion in the lung will appear, we will miss it basically. Another problem that can appear with these overexposed films is that sometimes we can falsely believe that the patient has maybe pulmonary emphysema, because we can not see the normal vasculature and interstitium of the lungs. So this is a normal chest X-ray in which we see only the first 3 vertebral bodies of the thoracic vertebral column, and this is an overexposed chest X-ray. Is more black. We cannot see lungs and parenchyma, normal parenchyma. We see all the vertebral bodies. On the other hand, this is an underexposed X-ray in which we basically cannot see any vertebral bodies. Like here, we only see a white, diffusely white shadow, and also we are unable to see what happens exactly in the peripheral regions of the lungs. They appear more white this time. So overexposed, more black lung parenchyma, and underexposed, more white mediastinum silhouette and white lung parenchyma. Another thing that it's essential when we study a film of the thoracic cavity is to determine whether the inspiration that the patient had when we took the film was correct. Usually when we take the X-ray, we tell to the patient to take a deep breath in order to for the air to reach all the alveoli and to uniformly and beautifully distend the lungs. If these things doesn't happen, then we will have images of partially collapsed areas of the lungs or improperly distended, and they will create the false impression that maybe something is wrong with the respective parenchyma. So in order to determine if the inspiration was correct, we will have to look at the number of ribs that we can see on the frontal chest X-ray. And how do we do this? We start counting the ribs. Usually I do it starting from the posterior arch to the lateral and anterior. So this is the first rib, this is the second rib, and so on and so forth. We count them all, and to say that the inspiration was complete, we have to find the 6th anterior arch of the rib that will cross with the diaphragm in the middle. So I have to see on the frontal chest X-ray 6 anterior ribs, or we can also see 9 posterior arches of the rib. So this is the first one. 1, 2, 3, 4, 5, 6, 7, 8, and 9. So I can safely say that this was a correct chest X-ray. And for the anterior, I go again from up. This is the first one. 1, 2, 3, 4, 5, and 6. And here the 6th arch will meet the diaphragm in the middle of the diaphragm. This is a more schematic representation of what I have just told you. Maybe it will be easier for you to exercise if you have the ribs colored, so you can easily follow them. So the 6th rib meets the diaphragm in the middle, or 9 posterior arches to determine if there is a correct inspiration when we take this fill. What you can see is the lungs are perfectly distended, and we see only vessels and no consolidation that will induce diagnosis problems. This is again an illustration of how to count the ribs correctly, so that you can exercise when you will read these workshops. This material will be posted on the classroom at the end, so I hope it's useful. It's useful to you. Okay, I'm gonna skip a bit this image because we will discuss it later more detailed. Okay, so if there are any questions until this point about how to correctly perform a chest X-ray, please.
I think it was pretty clear so far.
Okay. So we move on. After we would determine if the chest X-ray is nicely done and well inspired and centered. Oh, also what I wanted to say that it's also connected to the correctness of the chest X-ray is not to have any kind of foreign materials on the clothing of the patient, or not to have any jewelry imposed on the chest X-ray, because this will lead to funny images and diagnostic challenges sometimes, and you have to be sure that the patient has nothing on his skin or on his clothes when you take the exam. Also, part of the correct X-ray is to label with these signs that you can see here. Here is left mark. So in case you have a situation which is rare but possible to have dextrocardia, for example, you don't get into trouble because you don't know exactly if which part is the right or the left side. It is very important to have this kind of writing on the chest X-ray. Okay, so what do we have to analyze to determine whether the exam is normal or is something wrong with it, and how should we start? The way I do it is that I start from the exterior to the interior of the patient. I find it the most useful. It's a way that you cannot skip things and to focus on a main problem and forget about the rest. So if you try to look at all these things progressively, you will familiarize with the chest X-ray, and you will have good results in seeing different lesions. So what does this mean? so from the exterior to the interior, we have a lot of structures that make up the thoracic cavity. We start with the soft tissues, which are represented by the skin, the underlying fat, some muscles like the pectorals that project on the film. And we go deeper, we find the bony structures. These are represented by the ribs, the vertebra, the sternum, clavicles, and sometimes the scapula. Another part of the thoracic cage are the diaphragms, which close it at its inferior aspect. There are muscular structures and have specific appearance on the chest X-ray. If we go deeper, we find the pleural surfaces, which lie on the top of the lungs and beneath the ribs and soft tissue. Then, if we go a little bit deeper, we find the trachea and main bronchi with its divisions into smaller and smaller bronchi, which form the lungs. Also connected to the mediastinum are the right and left hilum, and inside and the most deep structure is the mediastinum, which is composed from a series of vascular structures and fat and lymph nodes, and we will see further and remember exactly how they look. So we will try to take it like this, and we start with the thoracic cage. I said, I'm sorry because it's a little bit blurry. I don't know, because in my presentation it looked good, but for the point of this presentation, I think it's fine. Bony structures. We have in the midline the vertebral column, which is much better seen in the lateral view. Each vertebra is formed from a body, which is this structure like quadratic structure here, connected with the pedicle to the posterior arch. So this is the body, this is the pedicle, this is the spinous process. And between two vertebrae, there is the intervertebral space. Another bony structure is represented by the ribs. The ribs have three arches, the posterior, lateral, and anterior arch. They connect to the spinal column in the back, and in the anterior part, they are continued by some cartilages that connect them to the sternum. These cartilages often with age tend to calcify and can determine a lot of opacities here around the sternum that we don't have to be scared about. It's a normal process. In the anterior aspect of the thoracic cage, we find the sternum. On the frontal view, the sternum is mainly included in the global silhouette of the mediastinum, so we cannot say many things. Here is projection, but we can very well study it on the lateral view, because we can see it very clearly in the anterior aspect of the thoracic cavity. As I pointed earlier, on the superior part of the thoracic cavity, there we can find the clavicles with the medial heads that we have to make sure are symmetrically positioned from the spinous processes. When you look at an X-ray in an frontal view, the spinous process will appear just like this rounded shape, because the X-ray beam will course somehow perpendicular on it. On the other hand, if we take a lateral view, then we can nicely display the spinous process on its length. Part of the scapula are sometimes projected on the thoracic film. Is something that we don't like because it obscures the lungs, but sometimes happens. We cannot make a perfect X-ray, and also we can see sometimes the proximal head of the humerus. What we have to do when we study these structures is to always look for their symmetry. So when I look at the clavicles, I look so that they are symmetric. The same is done for the ribs. I look on both sides, and any asymmetry, it will capture my attention, and I will find the problem. Okay, regarding the soft tissues, an image that you have to get used to is the shadow of the breasts that are can be found on the thoracic film. They should be symmetrical, and because of this shadow of the overimposed breast on the film, sometimes the interstitium of the lung can appear a bit more pronounced in these areas, only because there are a lot of tissues laying on top of each other, and when the beam passes through them, there will be a lot of structures that will appear on the film. So it's nothing pathological. You have to remember these things because the interstitial markings will be more prominent over the breast shadows. Also, it is important to note that sometimes in a patient with surgical intervention, maybe you will not find one of the breast shadows, and that is something that you must report on your result. The other areas of soft tissues that we can see on the chest film are the laterothoracic soft tissues composed by skin and fat that lies immediately under the skin, the axilla area where we can sometimes find lymph nodes opacities. We also we catch a bit of the inferior cervical area, so we have to look here too. Also formed by soft tissue like muscle, skin, and fat. And this is the normal aspect of the soft tissue and normal aspect of the breast opacities. Okay. Connected to the thoracic walls and part of this thoracic cage are the diaphragms. They are muscular structures that separate the thoracic cavity from the abdominal cavity. And on the X-ray, on the chest X-ray, they appear as opaque, dome-shaped structures that have really fine and undisturbed contour. They are linear like this, and we know that under the right diaphragm we will find the liver, and under the left diaphragm we will find the gas chamber of the stomach. So it is easily to identify the left diaphragm by identifying this little area of gas, which is found in the gastric fornix with the fluid level here. Okay, normally the right diaphragm is situated a bit higher than the left. It is because the underlying lever that is sitting here on the right, and we usually assess it like this. I'm trying to find something to to demonstrate. So this is the margin of the right diaphragm, and we draw a line that crosses to the most superior aspect of the right diaphragm, and we measure this distance here between this line and the left diaphragm. This distance should not be higher than 3 centimeters. If it's higher, then we will say that the right diaphragm is lifted. This can happen in a series of abdominal pathologies, like, for example, a very big liver tumor that will compress the diaphragm and lift it up above 3 centimeters than the left one. So this is the normal aspect of the diaphragm. On the frontal view of the chest X-rays, the diaphragm attached to the ribs and form the costophrenic angles, which are these sharp angles, and also form an angle with the heart, silhouette here, and these are called cardiophrenic angles. Okay, so diaphragms, right diaphragm, left diaphragm, costodiaphragmatic recesses or angles, lateral costodiaphragmatic angles, cardiophrenic angles. When we go on the lateral view, things are a little bit more complicated, because you will have sometimes the need to establish on the lateral view which is the right and which is the left diaphragm. It will be relatively easy if you keep in mind the things that I already mentioned, and that is the left diaphragm always has underneath the gastric air chamber. So if we move along to the lateral view, we will immediately identify that here is the gas chamber of the stomach. So most probably, I'm trying to find an eraser. Oh, sorry. Okay. So here is the gas chamber. So we will know for sure that this opacity here is the left diaphragm. This is one thing to look at. The other thing is that the left diaphragm, because it's close contact with the heart, will be obscured by the heart in its anterior aspect. So we can easily follow the left diaphragm right behind the heart, and from this point on it's slightly obscured by the opacity of the heart. On the other hand, the right hemidiaphragm can be followed on all its length from posterior to anterior, because it's not obscured by any other structure. Okay, here is the explanation for what I just said, so that you can have it and study it further. So stomach gas chamber immediately lies beneath the left diaphragm. the left diaphragm is shadowed by the heart, so we cannot see it entirely in the anterior part. On the other hand, the right diaphragm is visible on all its length and is not shadowed by any other structure. Okay. Passing along, we finished with the soft tissues and bony structures. We moved along to the diaphragms and the costodiaphragmatic angles. These are the lateral costodiaphragmatic angles, cardio diaphragmatic angles, and here are the posterior costodiaphragmatic angles. This is the first region when where the fluid accumulates if we deal with the pleural effusion. And they will obscure these angles here, so it is important to note them and to make sure that they have these sharp edges and they are transparent. Okay, along all these surfaces there is a coverage of pleura that lines all these spaces, all the costodiaphragmatic and cardiophrenic angles. The pleura also lies on the edges of the mediastinum and all the surface of the lungs. This is something you have to keep in mind and remember, because we will discuss further along in a few minutes. So getting even deeper in the chest X-ray, we will start to analyze the trachea and bronchi. So this is very easy because the trachea contains air, which will determine this lucency inside the mediastinal shadow. So it's practically the only normal lucent thing in here, and because of this contrast that it makes with the structures around it, it's very easily identifiable and very easy to study. So the trachea is this band here in the midline, a little bit black or darker if you want, similar to the lungs, as compared to the other structures that are very white around it. So it's this band in the midline which has very regular and parallel margins. It has the same width on all its length, and at the level of the fourth or the fifth thoracic vertebra, it divides in the two main bronchus, the right main bronchus and the left main bronchus. This bifurcation or division is called carina, and it is situated, as I said, at the level of the fourth thoracic vertebra. Okay. What I would like to say in addition to this, so these bands discretely loosened than the rest of the mediastinum are the trachea and main bronchus. The right main bronchus is it continues downwards the trajectory of the trachea, but the left main bronchus is a little bit longer and a little bit more horizontal than the right one. This is something important to keep in mind for the following explanations, because we pass on to the regions of the hilum. The hilum represent the structures where the vessels go in and out to the lung, the vessels and the bronchi. the left hilum is always situated 1 or 2 centimeters above the right one, and this is caused by the trajectory of the left pulmonary artery. The left pulmonary artery does like a loop that goes on the superior aspect of the bronchus, and it passes the left main bronchus from the ventral to the dorsal along the cranial aspect. And this is why, because this trajectory of the left pulmonary artery, this is the reason why the left hilum is situated above the right one. Okay. After the region of the hilum, the arteries will divide further in smaller branches, which will form the markings of the interstitium of the lungs. Are these band-like and discrete opacities that divide into further smaller branches that constitute the normal vascular markings of the lungs. The vascular markings are more prominent in the basal and inferior aspects of the lungs because of the gravity effect on them. It is very easily visible that here we have pronounced vascular markings. Then in the apex region of the lungs, where the aspect is much more clearer. This is a normal thing, and in the situation in which a patient is examined in upright position, in posterior anterior projection, if we start to see a lot of vascular marks in the apical regions of the lungs, then we should think there is a slight problem. So this is a normal aspect, with the markings more prominent at the base of the lungs, under the hilum. This is a representation of what I told you before, the right pulmonary artery and the left pulmonary artery, which courses superior to the left main bronchus to get on the dorsal aspect of the bronchia. If we look on the lateral view, the right main artery projects anteriorly to the left artery. This is the difference in the vascular markings that I told you about, much more prominent at the inferior aspect of the lungs compared with the apical regions. This is a normal aspect. Also, as they progressively divide into smaller and smaller branches towards the periphery of the lung, these vessels will become so thin that they will not make any much opacity on the lung. So the periphery of the lung will appear much clearer because of the small dimension of this vessel and interstitium as it reaches the periphery of the lungs. Okay. After we studied the trachea and bronchi, we studied the pulmonary hilum, and then we go a little bit further and study the normal aspect of the lungs, the normal lucency, on which we find overimposed these vascular markings and this small linear opacity, which represent the interstitial aspect of the lungs. What we have to do is to in case we have a lesion, is to try to determine where is it situated in the lungs. Going back to our anatomy lessons, we remember that the right lung is composed of three lobes, the upper, the middle, and the inferior lobes, and the left lung is composed of two lobes, the upper and the inferior lobe. Each of these lobes are further divided into segments. In order to establish this division and to correctly identify the pulmonary lobes, we have to find and to remember that they are separated by two kinds of fissure. The major fissure, or the oblique fissure on the right, separates the inferior lobe from the superior and middle lobe. The major fissure, which courses from posterior to anterior on this fashion obliquely, why it's called the oblique fissure, and it separates the inferior lobe from the superior and the middle lobe. The horizontal fissure, which projects on the frontal X-ray somewhere around here, separates the superior lobe from the middle lobe, and this is the right lung. Each of these lobes will be divided into segments. I have a little diagram further along, but this is the most important thing, to know the lobes of each lung. In the left lung, we only have a major fissure, the major fissure or the oblique fissure, which separates the inferior lobe from the superior lobe. The left lung only has two lobes, because the middle lobe here, it is covered and it is pushed by the heart, and it is incorporated in the superior lobe under the lingular segments. So three lobes on the right, separated by the oblique fissure and transverse fissure, and two lobes on the left, separated by the oblique fissure or major fissure. Each time we deal with a chest X-ray, if we have an opacity that is located in the lung, in order to correctly assess in which lobe it's located, we need to have a frontal X-ray and a lateral X-ray. If we only have the frontal X-ray, we cannot always accurately say if the lesion it is in the upper or inferior or middle lung on the right, or the same thing on the left. So we need another view in order to correctly assess. Did someone wanted to say something? Because
Sorry, my mic came on. I didn't mean to.
Okay. Okay, so this is the segmentation of the lung. This is the normal aspect of the lung, which is a bit more more loosened than the rest of the structures, because it's composed of a lot of alveoli, which are distended with air. They are composed of a lot of bronchi, divided into a lot of branches, which contain air, and between these alveoli and bronchi, there lies the interstitium, with blood vessels and connective tissue, which give this impression like this opaque band-like structures, linear and small opacities. This is the segmentation of the lung. In order for you to recall the anatomy, I don't think that we will get into so much detail, but it is sometimes very easy to say that a lesion is located in the apical segment of the upper lobe. I mean, these are quite simple things, but for the beginning, we need to focus on this major anatomy, the division of the lobes. Okay, the deepest structure that we can reach studying the chest X-ray is the mediastinal contour and silhouette, which lies in the center of the thoracic cavity. What we analyze when we look at the mediastinum are its edges. There are a few vascular structures that form the edges of the mediastinum, and you will have to keep them in mind, because every time one of these edges is modified, we can think of the underlying structure that determine the change. So on the right side of the mediastinum, we have three arches. The superior arch is determined by the brachiocephalic venous trunk. The middle arch is determined by the right atrium, and the inferior arch, not always visible, is determined by the inferior vena cava. So three venous structures that determine the three arches on the right side of the mediastinum. The first and superior is the right brachiocephalic vein. The middle one is the right atrium, and the most inferior and the third one is the inferior vena cava, not always seen. On the left side of the heart, we will have a superior arch, which is determined by the left subclavian artery. Right under it will be the aortic notch, which is the most lateral part of the aortic crossa, the aortic notch. It will be followed by the medium arch determined by the pulmonary artery, and the inferior arch that is formed by the left ventricle. So on the left side, we will have the following structures: superior arch, left subclavian artery, aortic notch, middle arch formed by the pulmonary artery, and the inferior arch formed by the left ventricle. So there are some venous structures on the right side and some arterial structures on the left side. What you have to know is that in older people with advancing age, because of the changes that occur in the wall of the aorta, which becomes more rigid and tends to increase in size and to dilate, most of the times this arch will be determined by the ascending aorta, but it is something that occurs with age, and we normally think that here is the left brachiocephalic vein. But usually, if you will see on an elderly patient a very dilated superior right superior arch, it will be most probably determined by the enlargement of the ascending aorta. What we have to assess alongside these arches is the dimension of the mediastinum, which correlates with the dimension of the heart. Usually the transverse diameter of the heart, as you see measured here, should not exceed more than half of the entire thoracic cavity. It's called cardiothoracic index, and it should be less than 0.5 as a percent. The same thing that I said before, here is the aortic knob or aortic arch, and here you can see a more prominent or superior right arch, which is determined most probably by the ascending aorta. Another thing that we have to keep in mind is that the normal position of these structures, the trachea on the midline, the aortic notch on the left side, the right atrium, and the center position of the heart is a thing that we use to assess the normal position of the mediastinum. In some situations in which, for example, we have an obstruction in the one of the lungs, the collapsed lung will determine a traction of the mediastinum and a change in the normal position of the structures that will rapidly stimulate our attention in order to say there's something wrong going on, because the normal structures of the mediastinum are not centered correctly. So pay attention to the normal position of the trachea, the aortic arch or knob, and the correct position of the heart. Here are some lines that help us identify some mediastinal pathologies. These lines are determined by the at the contact between the lung, which is filled with air, and the structure that is more dense inside the mediastinum. And because of this difference in intensity, we can see these lines that delineate different structures in the mediastinum. So with green on both sides, there are the paravertebral or paraspinal lines. With red, you have the paratracheal line. So there is the region where the lung parenchyma goes closely towards the edges of the trachea, and the small soft tissue that lies between the two of them will determine this paratracheal line. The same is happening at the areas where the two anterior regions of the upper lungs come into contact and determine the posterior and anterior junctional lines. The same happens along the azygoesophageal retches and along the lateral edge of the aorta, creating the para-aortic lines. So sometimes when we have different kinds of pathology, for example, tumor developing somewhere near the edge of the trachea, it will determine bulging of one of these paratracheal stripes. The same if we have a tumor that develops somewhere in the intervertebral space, like a neurogenic tumor, for example, it will determine an opacity that will move the paraspinal stripe towards the lung and will enlarge this space. So these lines are useful into assessing pathology underlying in the mediastinum. Anatomically, on the lateral chest X-ray, we divide the mediastinum into superior and inferior mediastinum, and also the inferior part of the mediastinum is also divided into an anterior, middle, and posterior compartment. The anterior compartment lies anterior to the heart, and it basically contains this retrosternal fat, which radiologically it looks like this transparency, lucency. In the middle, we have the heart and related structures, and in the posterior, we have the vertebral column and paravertebral spaces, the esophagus and lymph nodes and other related structures, basically speaking. It is more difficult to evaluate on the lateral chest X-ray things that are happening in the most superior region of the mediastinum, because you can see at this level there are a lot of structures that come together at the same place. There are vertebral bodies, there are parts of the scapula and the arms opacities, so it's difficult to appreciate very, very good the pathology that develops in this area. That's why for the analysis of the mediastinum, the exploration done by computed tomography, it's far, far superior. Especially for the mediastinum, also for the lungs, but especially for the mediastinum. This is the clear retrosternal airspace. There are part of the lungs that come together in front of the heart. Posterior to the sternum, here in the inferior part, lies the right ventricle, lies the heart, and the most anterior cavity of the heart that comes here posterior to the sternum is the right ventricle. Also, the most superior cavity and most superior and posterior cavity on the lateral X-ray is the left atrium, and the most inferior and posterior, the left ventricle. I will have immediately diagram that will help you understand much easier. Other things that we from the mediastinum that we see on the lateral chest X-ray is the tracheal lucent band. So this is the trachea, seen from the lateral view, which continues with the right main bronchus. Posterior to it is the aortic arch, and sometimes we see the descending aorta projected anterior to the vertebral bodies. This is the transverse fissure of the lung, and this is the oblique fissure of the lung, which courses something like this. This is what I was telling you before. There are a lot of overlapping structures in the superior aspect of the lungs and the mediastinum on the lateral view, which makes the diagnosis of these regions more difficult on the lateral chest X-ray. This is the arm lifted above the head, but still overlapping here the superior part of the thorax, and these are the scapula on both sides, which moreover shadow the normal transparency of these structures. The vascular structures that I told you, the aortic arch and descending aorta, and in front of it, it's the projection of the pulmonary artery, and the opacity of the heart lying in the middle mediastinum, posterior to the sternum. This is the schematic representation of the cavities of the heart. On the frontal chest X-ray, we normally see only the right atrium and the left ventricle. Sorry. The left atrium is not seen on the frontal chest X-ray, only if it's very, very much enlarged, and the appendix is also very much enlarged, and it creates a supplementary arch on the left side of the mediastinum. Otherwise, we don't see the left atrium. The right atrium determines the middle arch of the right contour of the mediastinum. There are a bit awkwardly put. The inferior arch on the left side is determined by the left ventricle, and the right ventricle also does not normally appear on the frontal chest X-ray unless it's very, very much enlarged and it overpasses the left ventricle and reaches the inferior arch of the left side of the mediastinum. The same on the lateral view, the projection of the heart on the lateral view, with the most anterior cavity being the right ventricle, the most posterior and superior the left atrium, and the most inferior the left ventricle. Only a small part of the right atrium can be projected here. Usually here we have the projection of the pulmonary artery. This is also a schematic image of all the structures that project on the chest X-ray from the mediastinum to the pulmonary fissures that you will probably find useful when trying to evaluate your chest X-rays. And this is basically what I had to say about anatomy and the projection of different anatomical structures on X-ray. If you have any questions, please tell me and please ask me so that everything can be clear. And I will sip some soda.
I think
it's all
everything's
good so
pretty
far, yeah.
straightforward. Yeah.
Okay, I will see when I will ask you the next time to describe different structures so that I'm sure you completely understood. Okay, only as an introduction to what we are going to study next, I want to say that in different pathologies that we can find on chest X-rays, we will study three main kinds of abnormalities. We will discuss about opacities, about lucencies, and about mixed images. Just to be a little bit familiar with these notions, I would like to point out some examples and what they mean. So opacity is an opacity is a structure that is of an increased intensity. It's more white than the surrounding lung, which is our reference point, if you like. So in the image in the upper part of the slide here, we have a normally aerated lung, which is transparent with vascular structures, linear normal vascular structures on the right side, and we have a completely white lung on the left side. This whiteness is called an opacity, and in this case it's called a massive opacity. This represents most probably pleural effusion on a pediatric patient, and this is what we call an opacity, something that it's much more white than the normal lung parenchyma that is compared on the other side. The same thing goes for smaller opacities, but numerous, diffusely distributed in both lungs. We see these rounded opacities much more white than the normal aerated parenchyma, which you can see here, for example, in the upper part of the left lung that is spared by these lesions. Compared with this normal parenchyma, this lesion appear more opaque, more white. So these are opacities, multiple small confluent opacities or one large opacity that covers the entire left hemithorax. On the other hand, when we see an abnormality that is much more lucent than the normal lung, it's a darker color than the normal aerated lung, we call this lucency, hyperlucency, or hyper transparency of the lung, and this also pathologic. In this situation, we deal with a massive pneumothorax that collapses the left lung here around the left pulmonary hilum. This is the lung here, and all this is free air in the pleural cavity, which gives us this impression of great hyperlucency compared with the right lung. And in between them, there are the mixed images, which are composed of an opacity and hyperlucency. So these are the main things that we will deal with on the pulmonary workshops. We will take each one separately and discuss it until we will find a way to learn them and to recognize them. Okay, and the final thing that I wanted to say is that the specific sign in alveolar damage and alveolar air replacement by other fluids is this specific sign of a lucency inside an opacity. This lucency follows the route of the bronchi. We can see lucency that divides into two smaller branches and so on and so forth. This is called an air bronchogram, and it's found in alveolar syndromes, which mean any kind of fluid that replaces the normal air in the alveoli. So with this in mind, we will continue next time with the pathology